Good morning, everybody. Welcome to Pediatric Grand Round. Today our speaker is Dr. Melissa Garganta from the Department of Pediatric Endocrinology. Dr. Garganta completed her medical school at University of South Carolina. She completed residency and chief residency in Greenville Health System in Greenville, South Carolina, and went on for fellowship training in pediatric endocrinology at Vanderbilt University. She worked as a pediatric endocrinologist with Prism Health in Greenville, South Carolina, before joining Carilion in 2020. Her special interest includes endocrine bone health and metabolic bone disease, receiving training at the Vanderbilt Center for Bone Biology and working there to establish their first multidisciplinary clinic for children with osteogenesis imperfecta. Please join me in welcoming Dr. Melissa Garganta.
All right, thank you so much. Good morning, everybody. I'm excited to talk to you about one of my favorite topics today. I've made this talk kind of geared more towards residents and general pediatricians that send us referrals for bone health, but if there's any questions at any time, please just let me know, or if anything needs clarification, let me know. Get started. We're talking this morning about osteoporosis in children. I have nothing to disclose. I will be discussing some off-label medication use, but I have no financial or other disclosures. So our objectives today, I'd like us to get a good understanding of the difference between osteopenia, osteoporosis, osteomalacia, rickets. These are all terms that you'll hear in different settings, and there's some small nuances that make them different, and there's even differences in these definitions for adults versus children, so hopefully we'll have a good understanding of that at the end. We're also going to talk about the different causes of osteoporosis in children and also how difficult it can be to diagnose osteoporosis in children. And then we'll briefly at the end talk about our current management and treatment options for this problem in kids and some future treatments that hopefully will be available to our patient population soon. All right, so first some definitions. So you'll see on the side of your screen, there's some images. We have a 3T microscopy image of different slices of bone, that basically all is remaining is the mineral content. And then you can see some 2D microscopy where there's been special stains used. So the green stain is going to be your calcium phosphorus, your mineral of your bone. The pink part is going to be more your osteoid and marrow type tissue. So osteopenia is sort of a blanket term that just means low bone mass or low bone mineral content. It's really a radiographic diagnosis, and you'll see in different x-ray reports, osteopenia or regional osteopenia or general osteopenia will be a comment from the radiologist, and it just means that on plain film, those bones don't look as bright as they should. They look either thinner or just less dense than they should. It's not really a medical condition itself. Osteoporosis, this is where it gets a little confusing. It has a different definition in adults and children. And so you can see normal bone would be the picture at the very top, okay? Thick cortex that's mineralized, nice trabeculae that's mineralized with osteoid and marrow in between. Osteoporosis is the picture below. So very thin cortex, very, almost looks like holes in the bone. So much less mineral, much more osteoid. So you can see how that would be considered a brittle bone that would break easier because it has much less mineral. There's actual microarchitectural change. So if you look at bone from an osteoporotic patient under the microscope, it's going to look very different. Osteoporosis in adults can be diagnosed based on bone density alone. In children, there are more criteria, and we'll discuss that. So it's even not something that we can use sort of across all patients. Osteomalacia is a little bit different. It's a softening of the bone or lack of mineralization. So not necessarily a loss of bone mass, but an inability to mineralize due to calcium or phosphate deficiency. So the background of the bone is fine, it just can't harden. So it's more soft bones. When you have osteomalacia in a growing weight-bearing child, you get rickets, where you see bowing, you see flattening, and those changes that we look for on x-ray. So rickets is really a condition that starts in childhood, and then osteomalacia would be the term that we use sort of to span the life. So patients with osteomalacia are not necessarily brittle. They're not necessarily at more risk for a fracture, but they're more at risk for bone deformity. So I'm going to start with a case, and this is actually a real case that I saw in clinic a few weeks ago, and I'm following him up soon, and I share care with him with our pediatric orthopedist. So this is a 5-year-old boy who was referred to multiple providers and then finally came to me for multiple fractures. He was a term infant. He did have milk protein allergy, and so he was on a very hydrolyzed formula until age 1 and then transitioned to almond milk. He did have reflux, treated with Zantac as a baby, but that is resolved. He had a single seizure as an infant, and there was some discussion of whether or not it was febrile, but he had a normal workup, no seizure medication, no further issues after that. He has been diagnosed with vitamin D deficiency and is on treatment. Mom notes he's had terrible dental caries compared to his brother. He's had a lot of dental work under anesthesia, filling some caps. He even broke a front tooth during a fall. But otherwise, she feels like he's a healthy, active guy. His surgeries, he's had the multiple tooth extractions and fillings under anesthesia, and then he had open reduction internal fixation of his left femur fracture in January of this year, and that was done here at Carilion. Family history is really, really benign. His maternal grandmother has a diagnosis of osteoporosis. She's on oral bisphosphonates. She was not diagnosed until her late 50s, and she's never had a fracture. Nobody else in the family has any kind of bone disease. He has 2 brothers, one older, one younger, that have never had a fracture. His current medications, he's on a Flintstone multivitamin once a day. He's been prescribed Periactin by his primary care due to concern over poor appetite, although his weight gain is fairly steady, so mom does not give it to him very often. And he's currently on vitamin D, 2,000 units a day in drop form. As far as past medication use, really no steroid medications. He got Decadron for croup 1 time, otherwise no steroid medication. And he's growing beautifully. If you look at his growth chart, he has normal linear growth at the 15th percentile. It's what you would expect for his family. He's had a normal hearing screen, no concerns for vision or eye abnormalities, and really all of his physical exams, other than when he has a fracture, have looked really good. He sometimes will complain that his legs hurt when he's outside playing, but it doesn't really seem to stop him. And so this image is actually a tibial. You can see here, kind of a healing fracture is one of his fractures. But here's his total list I went through with mom fractures over a lifetime. So in 2018, he broke his left radius and ulna. He was 3. He fell getting off the trampoline, so he wasn't really jumping. He was climbing off, fell from a trampoline height onto grass, onto his arm. That was casted and healed well. The next year at 4, mom, and this was outside Carilion, so I don't have an image for this, but she said he broke his left leg at the growth plate, so some sort of Salter-Harris fracture, while jumping on a trampoline and was in a brace for a few weeks. 21, this is the image you see here. He fell down 2 steps on his from his front porch, so 2 steps onto just a sort of concrete pad at the bottom of his porch, and resulted in this significant femur fracture here that then underwent ORIF and was plated and repaired. And then again, earlier this summer, he broke his left leg, his left tibia, which is that previous image you see, while running in the yard playing with his brother, fell from a standing height onto the grass, limped a little bit, walked around for a week before saying, "Hey, Mommy, it hurts." They took him in for an x-ray and they diagnosed the fracture. And so one thing I want you to pay attention to, it didn't show up on this image, but is sort of just look at his knee and the image of the fracture there. Does anybody think that looks a little different? Yeah, okay, so just keep this child in mind and that image in mind. And so this is all evaluation that he had done before he came to me. So after, I think, the 2nd or 3rd fracture, he had a vitamin D level checked. It was quite low at 14. So he was started on replacement therapy, responded very well. A year later, his level had come up to 62. His mom stopped giving the vitamin D supplement, started on just a Flintstone once-a-day vitamin that contains 600 IU of vitamin D a day. So was checked again 3 months later after his 5th fracture, and it had dropped down to 42. And so our orthopedist restarted him on vitamin D supplement in addition to a Flintstone of 2,000 IU daily. He's had some labs done over the course of his different hospital visits, and essentially everything has looked beautiful. Normal thyroid function. He's had really no evidence of systemic inflammation. He's had a normal phosphorus, thinking of hypophosphatemic disorders, and he even has been evaluated by genetics and had a osteogenesis imperfecta profile sent for genetic testing, and this again was negative. Right? So remember this little guy, and we'll kind of come back to him and what we've done to evaluate him. So how do kids build strong bones? So it's a combination of things. It's kind of like a three-legged stool. And so if you have a three-legged stool, it's nice and stable and strong. If you take one leg away or shorten one leg, what's going to happen? It's going to fall over, right, and break. So first you have to have nutrition, and that's calcium and vitamin D. Does everyone have to drink milk? No, absolutely not. Like, older kids do not require cow milk, but they have to get a significant amount of calcium and vitamin D from food or supplement sources. The second thing that's key is movement, is exercise, just weight bearing, play. Kids need to play. They need to be running, jumping. Doesn't have to necessarily be weightlifting or yoga or gymnastics, but just routine running, climbing, being a kid. That impact on the bone is one of the biggest factors in building bone mass. And so children who are sedentary or are unable to move and play normally are going to be at risk for not building normal bone mass. And then finally, sort of the third leg of the stool, which is a very, very strong leg, is your sex steroid hormones. So puberty is the time of massive bone mass accrual. Children with delayed puberty or absent puberty are missing this piece. And this is why we see postmenopausal osteoporosis in adult women, is because of that lack of estrogen. Estrogen and testosterone are just very potent strengtheners of bone and very strong promoters of bone growth. So this is just sort of an overview of bone structure. So when we think of bones, we think of what we see on an X-ray, right? It's just this one big solid thing. It's actually a pretty complex organ. So breaking it down, bone is made up of multiple osteons, which have different cell types. The base of bone, so it's collagen. So if anybody's ever seen a construction crew lay concrete, okay, you know, they put the metal bars in, the rebar that strengthens it. That's the collagen, okay? And then concrete is poured on. That's the apatite, or the hydroxyapatite, or the mineral in bone. So it takes both. You have to have normal collagen and normal mineralization to have good, strong bone. So for example, children with OI, or osteogenesis imperfecta, there is nothing wrong with their minerals, okay? They can have plenty of calcium and phosphorus, but they have abnormal collagen. It's shaped wrong. The chains are wrong, and so the mineral cannot bind to it normally. So you can put them on all the calcium and vitamin D and phosphorus in the world, and they will still have brittle bone because the foundation, that it's like laying the concrete without the rebar. It will break. So this is a little bit intimidating slide. Really, the only thing I want you guys to take from this is to know that there's different types of bone cells. And the way I explain it to patients is we have the bone eaters, which is that Pac-Man ghost-looking thing at the top, and then we have the bone builders, which are the osteoblasts. Blasts build bone. And what I want you to remember when we get to the treatment is that for osteoclasts to work, to form and be activated and break down bone, you have to have activation of something called the rank ligand. Without that, you have no osteoclast activation. And so the two types of cells that we think about when we're thinking about osteoporosis and treatment are your osteoblasts. Those are of mesenchymal origin. These are the cells that build bone. They lay down new bone tissue. They are the ones that have alkaline phosphatase, which is the enzyme that's responsible for mineralizing bone. If you do not have alkaline phosphatase, again, you cannot mineralize bone. You will end up with very soft bones. And then the calcium and phosphorus is what makes that mineral. Osteoclasts are bone eaters. They break down bone, and they're actually from hematopoietic origin. They require that RANKL activation, and they attach to the surface of bone, and they form with those little dendritic-looking extensions, what's called a ruffled border, and it's a very acidic area. Basically, they secrete acid that breaks down that mineral and resorbs that bone. Bone remodeling occurs throughout the lifespan. So it's not just like you build a skeleton and then you're done. Everybody in this room is constantly remodeling bone. Every time you walk, you go upstairs, you cause little micro damage to your bones, and that is remodeled. Again, in older adults with osteoporosis, we see a disruption of this, and they do not remodel bone well, but you're constantly breaking down bone that's there and laying down new healthy bone. And so this is a nice balance. You don't want to build too much, or you'll end up with thickened bone in areas, and you don't want to break down too much, because then you'll end up with weak bones and also some calcium abnormalities. So what is bad for kids' bones? So bad for your bones are a multitude of things, but some of the big ones that we usually don't think about because they're kind of just part of our everyday life are pictured here. So dark colas, not necessarily all colas, but particularly dark, caffeine or not, so that doesn't matter. Those are bad over time for bones for a couple of reasons. One, they displace kids from drinking healthier options, right? So there's absolutely no calcium or vitamin D in a soda. There's really nothing redeeming except for the joy of caffeine. And I love Diet Coke, so I'm not banning soda at all. But it also contains, particularly the dark colas, contain a high amount of phosphoric acid, and that can be taken up into the bone, and it prevents normal mineralization and bone turnover. And so there's several studies, particularly in adult women, that show a direct link with soda consumption and increased fracture risk. And this is being looked at in kids, too, because now kids are drinking more sodas. And so really we just need to, you guys are probably already doing this anyway for weight gain and sugar and caffeine counseling, but just remind parents that, hey, there's another reason these kids shouldn't be drinking their Coke and their baby bottles. You could be potentially harming their bones. Medications, there are a lot of medications that affect bone health. Most of these are things that patients require, so we just need to be aware that these can have an effect. And so anti-epileptic drugs, particularly phenytoin, but also carbamazepine and valproic acid, a little bit phenobarbital as well, they all can have some effect on bone building, and it's a mixed reason. For example, phenytoin increases liver expression of an enzyme that breaks down vitamin D. Some of the other AEDs just inhibit vitamin D absorption or vitamin D action, and then there's some, kind of other unknown mechanisms where we don't really know, but we know kids that are on these medications for long periods of time are at risk to have low bone density. PPIs, which is something we use very generously, especially in the adult world. PPIs have been shown to directly increase fracture risk long-term and lower bone density. There's a couple of reasons for that. They think if you use it particularly over 30 months, almost 3 years of use, that you have poor absorption of vitamin D and calcium, but they also, PPIs lower your magnesium, and magnesium is crucial for parathyroid hormone function as well. So kind of a complex mechanism, but they can affect the bones as well. Steroids are probably the worst medication for bones, and this is typically oral steroids, but we have to consider our children that are on long-term high-dose inhaled too, that they're getting some systemic exposure, but steroids affect the bone from sort of a double-pronged approach. They inhibit your osteoblast function, and they activate your osteoclast. So they really just speed up bone turnover. So it's always important when I'm seeing a patient for low bone density or fractures to get their medication history and see if they've ever been on high-dose steroids for anything. And then body mass index, of course, obesity is a huge risk factor for low bone mass. Probably a combination of factors from being sedentary, and also increased adipose tissue causes increased inflammation and increased cortisol, which is going to have a negative effect on your bone. Very poor diet. If you're eating a typical American diet, you're probably not getting the calcium and vitamin D that you need. And then loss of activity, not that video games themselves cause low bone density, they're fine, but when kids are only playing video games and having screen time and they're not getting that play. How many minutes a day are kids supposed to play? Active play, moving around. 60, right? 60 minutes a day. How many kids are probably getting that, especially with COVID? Right, like none. So it's not just obesity that we think about. This is the time. You only have a certain amount of time to build bones. After that, we're all on the downhill, right? Like it's not going to get any better for us without medication. So that is the prime time. Play is so important for so many reasons. All right, so pediatric osteoporosis, what is it? If you ask 5 different endocrinologists that trained over the last 50 years, you're going to get 5 different answers. This is the most current definition, and this is from the International Society for Clinical Densitometry. So these are like the folks that, the governing body of DEXA scans, let's put it that way. But both of these criteria are required for a diagnosis of pediatric osteoporosis. So you have to have low bone mineral density and a clinically significant fracture history. And so the question is, well, how do you define that? So low bone mineral density in a child is a BMD 2 or more standard deviations below the average measured using DEXA. So really no other form of measuring bone density is really considered reliable in children at this time. And then clinically significant fracture history, they define that as at least one long bone of the lower extremity, so your femur, your tib, or 2 long bone fractures in the upper extremity, or a single or multiple vertebral compression fractures. And then again, was it clinically significant if the femur was broken in a car accident versus a child who fell onto the carpet, right? So you want to think about the mechanism and the trauma involved, and it can get very confusing, as some people might say, well, that's normal, he's a boy, he fell on the porch, he broke a bone, but maybe the impact of that in a healthy child would not have caused a fracture. So you want to really get good details of how these fractures happen. So what is the incidence? Well, we don't really know because we're not scanning kids, right? We don't do DEXA screening. So we know it's increasing because the number of children with chronic diseases who use the medications we just talked about or who are immobile are surviving. And so the amount of bone disease we're seeing in those kids is rising. Also, the historical differences and lack of firm diagnostic criteria makes it difficult to know exactly the incidence of this. There also, until recently, has been very poor normative data of what is normal bone density in kids because it's a moving target. It changes every few months to a year as they grow, and there is very little data that we can trust in children less than age 5. And there's also a wide variety of factors that contribute to the development of osteoporosis, and so you have to determine if it's like a primary osteoporosis where it's a problem with the bones themselves, or is it secondary to another systemic disease. So children who are at risk, and this is probably not all-encompassing, I'm sure I left some off, but these are children that we need to think about having low bone density and potentially having an increased risk of fractures or bone pain. And so pretty much any condition where you have impaired mobility, whether that's CP, a TBI, muscular dystrophy, SMA, anything that has impaired mobility is going to put these kids at risk because they're missing that weight-bearing exercise. Children with chronic kidney disease or transplants due to their medications and poor nutrition are very high risk. Anybody with chronic steroid use, anybody with chronic lung disease, celiac disease actually can be a risk factor if it's untreated, and that is due to gut inflammation and poor absorption of fat-soluble vitamins. Inflammatory bowel disease for the same reason. Untreated thyroid disease. We don't see that a lot in this country, but it is a risk factor. Or obese kids, like we talked about. And then anything that affects your puberty, whether it's just constitutional delay or Turner syndrome. We know that children with Turner syndrome are very high risk to have low bone mineral density. And then, of course, we know our genetic bone disease kids, our OI, hypophosphatasia, X-linked rickets. Those kids are obviously going to have low bone mineral density. But we think about our preemies with short gut, and then diabetes, both type 1 and type 2 diabetes are risk factors for low bone mineral density. So we've covered pretty much 90% of the patients I see on this list. So how do we measure bone density in kids? So we use something called a DEXA scan, dual energy X-ray. It uses 2 levels of X-ray energy to sort of differentiate between bone mineral content and soft tissue. The difference in the attenuation of the X-rays is what gives you kind of that picture, and measures the actual bone mineral content in grams. Now, this is a 2D image, not 3D, okay? This is not a CT or MRI, sort of just a fancy X-ray, but it does let us measure the actual minerals in the bones. In general, they're not painful. They lay on the table and the wand kind of moves over them, so it's a pretty non-invasive test. And in most places, it's widely available. this is an example of this is an adult DEXA scan report, but this is what most people think of when they think of a DEXA scan. Something that's very important to remember about DEXA scanning is it's what's called an aerial measurement. It's not a true 3D volumetric measurement. So you only get 2 dimensions. Now that's going to, in an adult bone, not be as big of a deal, but in a child bone that is much smaller, that can definitely alter your results. So you have to know what kind of machine you're using and how to interpret these results. The size of the bone cannot be detected by that scanner. So if you do not have a scanner that has pediatric interpretation software, every child is going to have severe low bone density because that machine is measuring their mineral content against norms for adults. So that's super important to remember. DEXA can also be used to measure soft tissue body composition, so like lean body mass and fat mass. So a lot of athletes will have DEXA scanning done for that purpose. DEXA in children, it's very important to remember that there's some challenges. Kids don't like to hold still, especially if they're younger or they have special needs, and it's the positioning of the patient and motion really matter for the quality of the image. You have to have the correct type of scanner. If it is a scanner made for adults with adult software only, it's not useful. It's a wasted test. You have to be able to analyze the scan. It's really helpful to have a pediatric radiologist to do that. And bear in mind, we don't have a lot of control data, and it's hard to interpret normal for something that's going to change every year. It's also important to know, especially in the endocrine world, that short stature can greatly affect it due to the size of the bone. So children who are abnormally short, like less than the 3rd percentile for their age, you'll get results that show falsely low bone density. So you have to correct, there's a formula, a mathematical formula that I do that maybe some of you have seen me do in clinic to correct for that. And then anybody with metal hardware, so anybody that's had a plate, like our patient case, or a rod, or any kind of screws, any kind of metal hardware, that's going to make your bone mineral density look falsely high. The advantages of it is it's fairly low radiation. It's not much more than X-ray. It's non-invasive. It's short, so you can get it done very quickly. And most hospitals and facilities have a DEXA scanner. Now, whether they have the correct software is the question. And it's fairly low cost. Usually, for most plans, it's less than $600 and covered by insurance. So it's sort of our easiest test to do. Interpreting the results is important. And so this is, you see here a DEXA scan of the hip, of the wrist, the lumbar spine, and the whole body. And those are kind of the 4 different types that we look at. In children, we use the lumbar spine, L1 through L4, and the total body less head. So these 2 images on the bottom. Those are the most accurate and reproducible. The hip in children and the wrist in children are not helpful at all. Because what do we have there? We have growth plates, a big growth plate. And growth plates are cartilage. They're not fully mineralized bone. So if you get a bone density of a hip in a child, of course it's going to be low because they don't have as much mineralized bone there. So it's very important to pick the right body part, and then understanding the scores. So most DEXA scan reports give you what's called a T-score. That is a measure of bone density loss compared to a healthy young adult. So that is not applicable to our patients. We have to interpret them differently. So no hips, no wrists, only lumbar spine and total body less head. Okay. And here in Roanoke, for you guys, if you're ordering one, really the machine that has the pediatric data, the Hologic machine, and that gets this report is at the Breast Cancer Center. So we get to send all of our kids to the Breast Cancer Center for their bone density test. Z-scores are what we use to understand bone density. So these are compared to the normative data that we have based on age, gender, and ethnicity. A Z-score of 0 would mean average bone density for that population. Greater than -2.5 is considered significantly low bone mineral density. Now, this does not account for those with delayed bone age or delayed puberty, because remember, they're using norms for their age, chronological age, not their bone age, not their pubertal development. So you have to sort of interpret these with caution still. So this is an example of a DEXA report. And out of all the stuff on here, I've circled really the only thing that's useful for us. So you can see how these can be very difficult to read, right? Especially when they're done at outside hospitals, you get all this useless information. But on this page, what is helpful for us is to know the bone mineral density of this lumbar spine and the age-matched Z-score. That's really all we need from this. All right. I did want to mention this because I think this is coming in the future for kids. They're using this more in the adult world, but quantitative CT is a much more accurate way to measure bone density because it's an actual 3D measurement. So it takes into account the size of the bone, and it shows just much better images, much better calculations of the actual cortical area, the thickness. You just get a better idea of the health of that bone. It's difficult to perform in kids serially, though, because the bone size does change. It's also a CT, so it's going to be much more expensive, much more radiation. So I think as this technique improves, this is something we may use in certain select patients. It's also not as widely available, as you would imagine, as DEXA scanning is. So how do we treat low bone density in children? What can we do for these kids? Well, I will tell you there's no FDA-approved medication for this. We do not have an FDA-approved drug to give kids with just a diagnosis of osteoporosis. So really, to treat these kids, a lot of it is supportive care and just strengthening the bone as best as you can. And so it really helps to have multiple teams and providers involved. So that definitely an orthopedist, bone health, so peds endo that does bone health. And then depending upon the cause of the osteoporosis, genetics and genetic counseling is very important for these families. If they are on medications that affect their phosphorus level, they can be at risk for renal issues and kidney stones. So we like to have our peds nephro involved. A lot of bone disorders can cause eye abnormalities as well, and so you want to make sure you have a pediatric ophthalmologist for these kids. And then some of these disorders, the genetic bone disorders, can result in hearing loss, and so having ENT and audiology on board is important as well. And so a true multidisciplinary bone clinic will have all of these providers for these kids. And physical therapy and OT is huge to get the exercise and get those bones moving. Dental care, teeth are made of bones, so most kids with poor bone health have poor dentition, and then nutrition, and of course, social work case managers to help just families deal with the issues and the burden that it can be to have a kid with bone disease. So medically, again, there is not an FDA-approved indication for this. There are indications, and it honestly is becoming standard of care in our circles, but it is not approved. Bisphosphonate medications. These medications have been around for years, widely used in the adult population, particularly in postmenopausal women. But the way bisphosphonates work, whether they're given by mouth or IV, is they are analogs of pyrophosphate, so they are taken up into the bone, just like phosphorus is. And when they are taken up into the bone, they get in that acidic area, and the osteoclasts intake them, soak them up essentially, and they induce osteoclast apoptosis. So basically, they turn off the osteoclast, so the scale tips in favor of bone formation. So it doesn't give you better bone, okay? It doesn't give you better, stronger bone per se. It basically just gives you thicker bone, so it improves bone mass, and that's how it's effective in reducing fracture risk. In pediatrics, we use this in all sorts of children. The first population to really use it routinely were those kids with osteogenesis imperfecta, but now we use it in all sorts of osteoporosis. The main side effects of bisphosphonate use is particularly with IV infusions. They can get a flu-like reaction with that first infusion, fever, aches, they feel really sick. The main side effect of all bisphosphonates is hypocalcemia. And the reason for that is you are shutting down bone breakdown, and that is how our body keeps our calcium normal, is we liberate our calcium from bone. Over 2/3 of our body's calcium is stuck in our skeleton, and if we can't liberate it, then we're going to be at risk for low blood levels of calcium. Long-term effects, there's some, I mean, we're about 30 years out from some of the first studies in OI and this drug in kids, and it's very well tolerated. We do know that it can, because it shuts down bone remodeling, it can delay bone healing. So we try not to give kids these medications within a few weeks to months of orthopedic surgery. So if they're having a rod placed or some kind of orthopedic surgery, we'll hold the medication around that time. If you take it too much, remember, it doesn't give you better quality bone, it gives you thicker bone. So if you're on it long term and not monitored, you can actually get what's called osteoporosis, which is too thick bone, which is a risk factor for breaking as well. It's like porcelain, might be very thick, but it's too hard and it can shatter. And then particularly the oral bisphosphonates are terrible at causing reflux and esophagitis. They have to be taken with a lot of water. You have to be upright for about an hour after you take the tablet due to the risk of reflux. Potential side effects that are reported in adults are atypical femur fractures, usually at the hip, osteonecrosis of the jaw, and orbital inflammation. There are no reports in any of the studies that have been done, no reports of that in children. And then growth impairment was sort of a theoretical cause because, again, you're shutting down bone remodeling, but that has not really been shown, and we actually see that kids, particularly with OI, grow a little bit better on bisphosphonate therapy. And then we do think they are teratogenic because they are going to be taken up by the skeleton of a fetus, and so we do not use these medications in pregnant women at all. And you can see there's a very cool picture at the top. This is a patient with OI who has some rods placed, but you see the stripes on their bone? Those are called zebra lines, and that's when that child has had their infusions of IV bisphosphonate. And so you can, those basically, it's almost like rings in a tree. You can see how often they've had an infusion, and it just shows the difference in bone growth and strength when they get that infusion. And these aren't harmful. They tend to go away over time, but if you see these on an x-ray, that's most likely what it is. Okay. This is just to show you, definitely you do not have to read through this, but just to show you the amount, and this is just a small sampling of studies that have been done with multiple bisphosphonates in children with positive outcomes in multiple disorders. So there's a lot of studies out there. There's a lot of support for their use. We just don't officially, have a guideline and a FDA approval yet. All right. I did want to briefly mention Denosumab. This is an amazing medication that's now sort of coming in favor over bisphosphonates in the adult world because it causes much less side effects, particularly in adults with renal failure and renal issues cannot take bisphosphonates because they're renally processed and excreted, but they can use this medication. And so this is a human monoclonal antibody, and it binds to RANK-L and blocks it from activating the osteoclast. So remember on that slide way at the beginning, I said, remember RANK-L is required. And so this medicine targets there. So it does not have to be taken up into the bone tissue. It does not have to wait for the osteoclast to soak it up and die. It just prevents activation. So again, it works the same way in that it tilts the favor of the scale to bone building instead of bone breakdown. But it's a single injection, subcutaneous, so not very painful injection once every 6 months versus a several-hour IV infusion every few months or a very large pill that they have to take all the time. It has similar side effects to the oral bisphosphonates. It does not have the flu-like reaction that the IV ones do, and the studies are all showing superior improvement in performance of this medication in postmenopausal women. There are a lot of studies, particularly in children with OI, with this drug now, and so honestly, our best bet at eventual approval for a medication is probably going to be with Denosumab. So you will not see me prescribe this just yet, but hopefully very soon. Okay, so vitamin D and calcium. There was a lunch and learn, awesome lunch and learn earlier this week about this, so I'm not going to really kind of go all through that, but what we need to know is that all patients need this, healthy bones or not. Vitamin D and calcium, and they go together, okay? So if you replace a vitamin D deficient child with vitamin D and they have very low calcium in their diet, you've only got one part of that leg. You need both. So the goal vitamin D level, we think of it as 30, but for children with known osteoporosis, bone disease, at risk, the orthopedic physicians really feel that level needs to be 50, and they're the ones in there looking at that bone, right, in the OR, and they can tell a difference in bone quality in kids with vitamin D deficiency. So we really shoot for a level greater than 50 in our bone kids. The recommended daily intake, that does not mean they're going to have a normal level. This is just the minimum they should get. For infants, it's 400, and then everybody over a year, it's 600 to 1,000. And then this table on the other side of the screen is the recommended daily allowance for calcium. You can see that increases with age, with females needing slightly more than males. But basically, most of our patients, school age and teenagers, need at least 1,000 milligrams of calcium a day. So why can't they just eat it? Well, vitamin D is found in very few foods that children eat. So other than milk, I can't really think, I have a 7-year-old, and I can't really think of anything on that list other than a little bit of cheese that he will eat. So most of our kids are not eating rainbow trout and sockeye salmon. If they are, that is fabulous, but it's just not happening. And I don't even want to talk about sardines or liver, but it is not found in a lot of foods naturally. Now, it's fortified. It's added to things like cereals, so you can get it fortified. But even if a child is like, well, they eat cheese and yogurt, there's actually very little vitamin D in cheese. They would have to eat 400 ounces of cheese to really get. So it's just not, it's really not a good source like we kind of commonly think of. And then the other picture, those are calcium-containing foods, okay? So if they're not milk drinkers and they're not getting calcium-fortified foods, these are where it's naturally found. And again, not a lot of things that our kids eat. So even though we really think about vitamin D a lot of our kids are probably not getting enough calcium in their diet, especially if they are not dairy drinkers. So exercise, super important for treatment. So weight bearing is essential, as we've talked about. Studies show that exercise programs in schools, so PE, planned playtime, increases annual bone accrual in children. So this last year where all of our kids have been home and they've not had PE and they've not had recess, I think we're, eventually going to see some effects from that. So prepubertal kids, it's necessary to get that exercise. And children who are high risk of fracture, aquatic exercise can help. Now, that's not really weight-bearing, but it improves bone health by just improving that muscle strength, tension on the bone, overall fitness, and it's a good way to get them exercise and improve mobility without increased risk of fracture. And then PT is necessary for any child with mobility issues. Stretching, just pushing on the bones, using a stander if they're immobile, just getting that child up where gravity can have effect on their legs is huge. All right, let's go back to our little guy. So this is our little guy that's had 5 fractures. He's broken a very bad fracture of his femur, tibia once, maybe twice, but one's kind of iffy, and then radius and ulna once. Labs look good. He does not have any medication risk factors. He is not obese. He is not inactive. He does not have OI. We really couldn't find any medical condition that would cause him to have secondary osteoporosis, and he does not appear to have a genetic bone disease. We know he doesn't have hypophosphatemic rickets. We know he doesn't have OI. He doesn't have most genetic things just because he's a healthy kid. He doesn't really have any other comorbidities. But so what I did was get a DEXA on him, and this is his actual DEXA report, and this is what we want to see. A whole body, less head, and a lumbar spine with Z-scores. And I know you don't have to read the tiny print, but I just wanted to show you this was done at the Breast Cancer Center on the correct machine with the correct software. So this is what we're looking for. And so his DEXA shows a lumbar spine Z-score of -3.2 and a total body of only -0.9. Now, why do you think there's such a discrepancy? Was that?
The metal plate.
The metal plate. Yeah, so when we got this DEXA done, he has a large metal plate that spans most of his femur and several screws. Now, how much that alters it, I don't think we really know the amount, but definitely it's going to alter it a little bit. But that lumbar spine is terrible. It's very, very low bone mineral density for this child. Labs, I got a PTH to screen for hyperparathyroidism, totally normal. His calcium, his phos has been normal now twice. And I got an alkaline phosphatase level. Does anybody know what I was looking for with that? What disease? Hypophosphatasia, that is right. So remember, lack of alkaline phosphatase, you can put all the collagen you want, but you can't mineralize it. That's a very normal alkaline phosphatase for his age and gender. So normal labs, he does not appear to have any metabolic bone disease. What's wrong with him? So I don't really know. He's following up with me, and it's going to be a conversation between me and his orthopedist trying to figure this out a little bit. We know he had pretty significant vitamin D deficiency. That's been treated for over a year, and he's still on treatment, and I don't know if that was enough to cause this, because how many of our children are severely vitamin D deficient? So I think he has something else going on. This is the diagnosis I was kind of suspecting, but as you'll see, he doesn't really meet all these criteria. But juvenile idiopathic osteoporosis is pretty rare. We don't really know how rare, because there's probably children out there with it that we don't catch. But it is a disorder unique to prepubertal children. We do not know the cause. It occurs anywhere 1 to 13. Most kids are around 6 to 7 when it's diagnosed. And it is a diagnosis of exclusion. You have to exclude all other causes of bone disease first. The first sign is usually pain in the lower back, where you have the most low bone density seen. Hips, feet can cause difficulty walking. They can also have some knee pain, ankle pain, pretty much anywhere in the lower extremity, and lower extremity fractures are more common in this disorder. Some things you can see, but not necessarily in the more mild cases, is kyphosis of the spine, poor growth. They can have sort of a sunken chest appearance or a limp. The x-rays will show regional osteopenia, which our little man's x-rays did. They'll get fractures of weight-bearing bones, and you can see collapsed or misshapen vertebra. The treatment for it is really the same treatment as it is for all children: vitamin D, calcium, weight-bearing as tolerated with PT, avoiding contact sports, okay, so they cannot play football, they cannot wrestle, and then rarely bisphosphonate use. It has been showed to speed healing, but it is not commonly used in this condition yet. The important thing about IJO is that it resolves with puberty. So most patients, after they go through puberty, they're exposed to sex steroid hormone. They have complete recovery of bone tissue. And so long-term issues with this disorder are rare. So he may have this. We're not sure. All right. So in summary, this is Ozzy, the osteoclast. He sits on my desk. Osteoporosis is difficult to diagnose in kids due to difference in presentation, multiple different causes, unclear criteria, and the specific needs that we have to get a proper DEXA scan. The DEXA has to be performed and interpreted correctly, or it's not helpful. We are seeing it more frequently due to these chronic children surviving and thriving and having poor bone health as a result of their condition. Again, there's no FDA-approved treatment for these children right now. And most important for you guys, seeing healthy kids every day, nutrition, exercise, puberty, all those things are necessary for normal bone health. All right, so I got some questions. Okay, so I started with the easy one. So which of the following factors affect bone health in kids? So that was the easy one, okay. So next one. So we have a 14-year-old football player. This is a real patient I saw as well. He came due to concern of low bone density on a DEXA scan and multiple fractures. He had 2 fractures of his hand, one in his left foot that was not healing well, mainly because he was not staying off of it. And then all 3 had occurred either during a football practice or a football game. He's otherwise a healthy guy, normal growth development, no high-risk medications. His PCP obtained a DEXA of his wrist and hip and referred him to me because the T-score was minus 2.9 and minus 2.7, and she had diagnosed him with osteoporosis, and so was very concerned. His labs revealed a vitamin D of 19, normal calcium, normal phosphorus. So what does he have? I got one answer. That's right. Yeah. So does he have osteoporosis? No. Why not? It's vitamin D.
So they're not accurate in the kid.
Yes, exactly. So these fractures, one, they're not long bones and they're not compression fractures, and there's probably a reasonable mechanism. Also, this DEXA is completely, unfortunately, a useless study. They gave us T-scores and they examined the wrong body parts, so not super helpful. Now, he does have vitamin D deficiency, which we treated, but really that's his only diagnosis. Okay, last one. So this is a 7-year-old girl, also a real patient with OI, who was doing fairly well, but then started to break a little more as she got a little more active. Her most recent fracture is she broke her right femur, snapped it into just falling from the couch onto the living room floor that was carpeted. So we got DEXA on her. It was pretty horrible. Appropriate DEXA of spine and whole body left head revealed very, very significant low bone mineral density. So the family decided to proceed with IV infusions of zoledronic acid or zoledronate to help improve her bone density, reduce her fracture rate. What is the main side effect that she's at risk for with this IV medication? Yeah. So hypocalcemia. Yeah, so esophagitis would be if it was an oral. Okay, oral bisphosphonate. Transaminitis is really not seen, more kidney-related function. And then osteonecrosis of the jaw, again, there are no reports in pediatric patients of that. All right, those are some references. Okay, questions, comments, thoughts? Go ahead.
One question. In the health and density of kids, I'm used to thinking of weight as being kind of a protective factor for bone density, especially in adults. More so that way in kids just based off the activity level. You explained this in relation to hormones, but it won't be affected the same way by obesity in adults.
Yeah, so in the adult world, it is considered protective over, versus a very thin older woman. And I don't, a lot of the menopausal issues play into that. In kids, it's considered a risk factor usually because of lack of exercise. And also, we do know that kids with obesity have increased inflammation, have higher circulating levels of cortisol. And so we think that that's probably the main mechanism as to why.
Cortisol would be high in an obese adult as well, right?
Yeah, presumably. Mm-hmm.
Screening for osteoporosis in children on chronic steroids or AEDs?
Yeah, that's a great question. So there's really no specific guideline. Certain conditions, so like Turner syndrome, there is a specific guideline. Those young ladies need DEXA scanning starting at a certain age. But really for, these chronic children, chronic steroid use, even like muscular dystrophy, there's no set guideline. So most centers are now getting DEXAs in DMD kids. I think that all kids with CP or transplant kids or chronic steroid use probably do need a DEXA scan at some point. And then the discussion would be, and the research that needs to be done is what age is best, what interval is needed, and those are things we just don't have the answer to yet. So unfortunately, a lot of the times we sort of just wait until they've had a fracture or they're having pain, and then they get evaluated.
The patient from the beginning.
Yeah.
That knee.
Yeah. So that knee, so the radiologist read that as significant osteopenia. And so what I wanted you guys to notice is just that it looked abnormal. And here, let's go back to that, actually.
Looked like it had a significant bone spur.
Here we go. Okay. Not exactly what we're Okay. Yeah, so, but this is not the best image, especially when projected this large, but bones should be bright white, right? And so you can just see here, it's just not as bright. It's a widened, so he has a widened epiphysis. Now, he does not have flaring or beaking, which is sort of what you see here when we see rickets. Like, this will be really kind of upturned. The border of the growth plate will look fuzzy, almost like it's eaten away. That's very common in rickets. But you can see it just does not have that precise, nice, crisp edge to it. And like here, his growth plate is just very irregular and kind of blurry looking. Again, not the best image, but it tells you that there's something else going on other than the giant fracture that's right there.
How long do you typically treat with bisphosphonates or in the kids? Could that be a short period of time, so that why we're not seeing potential complications like with adults?
Mm-hmm. That's a great question. So it kind of depends on the condition. Typically, like our kids with OI, that's the most common population we use bisphosphonates in. We'll treat for several years until, and watch DEXA scanning every year. And once we get those Z-scores usually significantly improved, -1 or better, we'll often give them what's called a drug holiday or a break off of that, because we know that they are taken up into the bone and they do remain in the bone tissue for up to several years. And then if the DEXA shows decline, worsening of bone mineral density, or they start fracturing again or having significant pain, like a back pain, then we'll restart. But there's really no 2 years on, 2 years off kind of protocol.
Like this young man, if he does have idiopathic reasoning behind his fracture, would you consider starting puberty early with testosterone therapy to avoid massive fractures like these if he continues to have them, or you just kind of help him ride it out?
Yeah, that's a thought you could, but he's only 5, so we have quite a while, and you don't really want to compromise stature and alter his development. So if he's had a good amount of fractures, and so the conversation that I think I'll have probably with Dr. Zielinski and Mom is, is this a child that we want to try an oral bisphosphonate on to see, because we have a lot of years until puberty, to see if we can reduce his fracture rate so that he can go and be a kid and play with his brothers. And so that's, there's really no guideline for that. I've done it, before, and it's sort of a decision between, kind of the whole team as to what's best. But I am considering doing oral medication in him just to get us a few years.
Essentially, temporizing measure to get it.
Yes. Yeah, because now when he goes through puberty, if it's idiopathic, it should resolve on its own. But, for a boy, that could potentially be another 7 years, so 6 or 7 years. Good questions, guys. Anything else? Okay. I don't see anything in the chat, so we're good? Okay. All right. Well, thank you, guys. Have an awesome day.